Here is a case of a 30-year-old male patient with lens coloboma and intact zonule, as we can see for right eye, and the left eye was done elsewhere using a flange technique to fix Cionni through the sclera to fix the capsular bag. My plan was different for this case. Actually, I'm going to fix the capsular bag using Cionni through the sclera using the Gore-Tex suture. I started with the conjunctival peritomy, as we can see, then creating a scleral pocket about 2 mm from the limbus, 2 paracenteses, and main phacoincision 2.4, as we can see. Actually, in this case, I'm going to create the capsulorhexis using the Capsulaser technique, which is very helpful in creating a well-centered, well-sized and easy performance of the capsulorhexis. I put some viscoelastic in the area where the defect of the lens. Then I inject the capsule blue under the air bubble very slowly, as we can see, followed with wash out the capsule blue, then injecting the dispersive OVD to prepare the anterior capsule for the Capsulaser capsulorhexis. Here we can see the laser circle. It's 5.3 mm in diameter. Here applying the laser, as we can see, in 0.3 seconds we can create a very good rounded rhexis. As we can see, there are some tags. We can remove it. It's very easy to remove. Now I have 5.3 mm diameter capsulorhexis. Then hydrodissection. Actually, this is type of cataract is very soft, and it was easy to remove that cataract. As usual, using the phaco, then followed by manual irrigation aspiration. One important step here is to maintain the antechamber and also the capsular bag before taking out the irrigation probe or the phaco probe, as we can see, to prevent collapsing of the capsular bag. Here is the 8-0 Gore-Tex suture, which is double arm. I change the curvature of the needle. As we can see, I make it slightly straight. Then 1.5 from the limbus, introducing the 8-0 needle, then extrude it through the main phacoincision, then pass it through the eyelet of the Cionni ring. Then implanting the Cionni ring inside the capsular bag. Actually, it was a difficult step here. Inserting in the same direction of the defect in the lens. Very slowly rotate until be sure that all these CTR, the Cionni ring, is settled properly inside the capsular bag. Here is the second eyelet. Actually, there are two types of Cionni, with one eyelet or two eyelets. I'm using the two eyelets because the one eyelet is not available. Now all the Cionni ring inside the capsular bag. Then 27 gauge needle introduced through the scleral bucket underneath the iris, and dock the 8-0 needle Gore-Tex, then extrude it through the scleral bucket. Now I have 8-0 vicryl suture passed through one eyelet of the Cionni ring. Now rotate the Cionni ring and change the direction of the eyelet to be opposite to the area where the maximal defect of the lens or the subluxation, and pushed slightly, and before tying it, implanting 3-piece IOL inside the capsular bag. Here is enlarging the main phaco incision. Here is 3-piece IOL. Implantation inside the capsular bag. Rotate until be sure that the haptics inside the bag. After that, we can tying the Gore-Tex suture and push it to be sure that the IOL is centered properly. As we can see, then wash out the viscoelastic using the bimanual irrigation aspiration. Look at the IOL, it's very good centration. Then stromal hydration of the paracentesis and main phaco incision. I inject myocol to constrict the pupil. Here it's very clear the centration of the IOL. Here is the myocol and the pupil is constricted. Now back to the Gore-Tex suture. Complete tying of this suture for 4 or 5 knots, as we can see. Then the knot is buried properly through the scleral pocket. As it's clear and this scleral pocket is closed properly using 80 vicryl suture. Just 2 sutures as it's clear. Then the conjunctiva is back to its position and fix it through the forceps cautery. And here is the end of the surgery. Let's see the patient on next day. The cornea is very clear and the vision of patient improved from 2400 to 2028. Here is 1 week after the surgery. I dilate the patient. We can see the IOL is well centered and there is no tilt as it's clear. And look at the beautiful capsular rhexis and compare this eye with the second eye. While the capsular bag is fixed with flange technique, here is the second eye. We can see the flange through the dilatation and we can see the rhexis, which is slightly decentered rhexis. And thank you for watching.